Hey guys, welcome back to the channel. If you're new here, my name is Ali. I'm a final year medical student at Cambridge University, and this is part of our Medical Ethics for Interview series. And today we're going to be talking about consent, capacity, and Jehovah's Witnesses. If you look in the description below, you'll see timestamps to absolutely everything that's mentioned in this video, so you can see what the structure is of the video. But first, I'm just going to give you a 30-second summary of what we're going to talk about, and then the rest of the video is going to be us discussing cases relating to that summary and kind of expanding a little bit more in depth about what the deal is with consent, capacity, and Jehovah's Witnesses. So here's the 30-second summary. Basically, we need consent before we operate or do anything on anyone, because if we don't, then that's assault. So consent is really important. Someone can give valid consent if it's 1, voluntary, 2, informed, and 3, competent or capacitous. We can assess capacity by asking them to 1, understand, 2, retain, 3, weigh up, and 4, repeat back or communicate their decision to us. If they're a kid, i.e. under 18, then they can consent to treatment provided they have these 4 things of capacity, but they can't refuse treatment. If they refuse treatment and their parent wants to accept the treatment, then we override their refusal and we are allowed to do the treatment to them because the parent has consented on their behalf. If a patient doesn't have capacity, we look to see if there's an advance directive or if there's a lasting power of attorney. And if not, as is the case most of the time, then we as doctors operate on a best interest principle in that we do whatever we think is in the best interest of the patient. So that's the 30-second summary of this whole kind of capacity consent area. But now the rest of the video we're going to be expanding on these points in a bit more detail. So ideally you want to be watching those so you can actually understand what the cases were behind these and what the principles are that we're going to be tackling. We're now going to cut to a video of Charlotte and Molly, who you might have seen from last week's video, and they're going to be introducing the case that we're going to start off with. So here are Charlotte and Molly coming up.
Hi guys, it's Charlotte and Molly again. So we... Stop it! Hi everyone, it's Charlotte and Molly again, and this video we're going to be talking about consent. And we're going to start by thinking about a real case. So this is a case in which there is a lady who comes into the hospital and she's pregnant, she's at term, so her baby's ready to be born, and there's some complications that mean she needs a cesarean section. Baby's in distress and we need to get baby out. And the medical team approach her and ask for her consent, and initially she will give her consent to have this surgical procedure. But at the last minute, she withdraws her consent because she's terrified of needles. And she says, no, I don't give my consent anymore. You can't do it. And so in this situation, mum has withdrawn her consent and baby is in danger. What would you do as a doctor in that scenario? If you were part of that medical team, how would you go about dealing with it?
Okay, so that's the case. We need valid consent to save the life of both the mother and the baby. This is re MB. But the mother has withdrawn her consent at the last minute. So, what do we do? If you got this in your interview, how would you respond? This is a very classic case, and I think it's the kind of thing that they might want to ask you about in interviews, just so you can have a little bit of a discussion about what the ethical issues are in this case. So, as we mentioned in the last video, you might be talking about autonomy, beneficence, non-maleficence, and justice, but I'm not going to go into those in detail because you can probably just make those up on the spot. Instead, we're going to talk about the specifics behind capacity and consent and what the deal is with that, and that's what this video is going to be about. So, in answer to this question of what do we do if we don't have consent, we first need to understand what valid consent actually means. So, now we've got a segment of Charlotte and Molly coming up where they're going to explain what the 3 components of valid consent are. It is definitely worth knowing about this in your interviews because scenarios involving consent are surprisingly common. And if you can mention in your interview that, right, to have valid consent we need these 3 things, informed, voluntary, and competent, then that looks very, very impressive. And if you can understand a little bit more about them, you'll be able to kind of draw them into whatever question involves consent. So yeah, Charlotte and Molly talking about the 3 components of valid consent. Here we go.
Okay, so in law, consent is only valid if it is voluntary, it is informed, and it is competent. And so we'll talk a bit more about what those 3 things mean and how we might go about checking if our consent has fulfilled those 3 criteria. So one example that we can talk about here is Re T, which was a legal case in 1992, and it involved a young woman who was pregnant at the time and actually was involved in a car crash which required her to have a blood transfusion. T was from a family of Jehovah's Witnesses who historically are opposed to transfusion of blood products for religious reasons. And this is often a really difficult case for a doctor to deal with because it can sometimes mean that a patient won't consent to treatment, such as a blood transfusion, that a doctor feels is actually necessary to help improve their health or even to save their life. So it's really important that we make sure consent is valid by being voluntary, but also that not giving consent is valid by being voluntary as well. So in this situation, T, after spending some time with her mother, who was a Jehovah's Witness, actually decided not to consent to this blood transfusion, which the medics deemed to be really important to save her life. And because they felt that actually she had been under pressure from her mother to withdraw her consent, that was deemed invalid consent in that situation. So there's an example of consent and not consenting having to be given voluntarily and not forced by anyone else.
So we've established that consent has to be voluntary, not given under undue pressure. The second thing that consent has to be is informed. So if you think about every time you open a box of paracetamol, there's a big leaflet that says side effects, risks, and there's a whole host of things written down there. And that's a kind of legal coverage for the pharmaceutical company. They have to tell you what the risks are of whatever you're taking. And it's the same in medicine. We have to be sure that we're giving our patients all the information they need to make a reasoned decision. So that includes all the benefits that could result and all the complications and risks that are involved. So that includes things like infection after an operation or side effects of particular medications. And obviously the benefits are that the disease will be cured, that they will have a better quality of life. And so we have to cover all that with our patients. And historically, we've used something called the Bolam test to decide how much information we should give a patient. And this idea is that if you stood up in court and you said, I gave the patient this particular set of information, and there were another group of doctors, another group of reasonable professionals of your profession, who would stand up in court and say, yeah, we would have done the same thing, then legally that meant you were in the clear. So if what you did kind of lined up with what another body of doctors would do, even if they're not a majority, then you were legally okay. Previously we've used this Bolam test, so we'd ask, what would the reasonable doctor tell a patient? So that was historically what we've done. But then in 1999 we had this case with a lady called Nadine Montgomery. And Nadine Montgomery was pregnant and she gave birth to a son, Sam. And she gave birth naturally, she had a vaginal delivery. Now during this there were some complications, and what happened, Sam basically got stuck. And that meant that he was deprived of oxygen for a period of time. It was over 10 minutes. And because of that, he subsequently developed cerebral palsy, which means that his brain had been deprived of oxygen and the brain tissue itself had been damaged. And so that's a permanent disability. So this happened, and Nadine Montgomery then took lots of legal advice about should she have been warned about the possibility that this complication that we called shoulder dystocia, should I have been warned about that? And she brought this case to court, saying that she should have been advised that there was a risk of this happening. She was saying that regardless of what the outcome would be, this risk was big enough that any reasonable patient would have wanted to know. And so we have moved away from the what would a reasonable doctor tell a patient to what would a reasonable patient want to know. And this went, it took many years to be resolved in the courts. And so now as a doctor we have to ask ourselves, what would a reasonable patient expect to know? And that will differ in varying circumstances. So imagine, for example, you're conducting an operation on someone's eyes. If the patient you are operating on already has no sight in one eye, then understanding the risks of visual loss in the other eye is going to be far more significant to them than someone who has perfect sight in both eyes, because that's the difference between that person becoming completely blind or still having one eye remaining to see with. So we have to make a judgment on a case-by-case basis about what a reasonable patient in that position would want to know, because it's impractical to say we'll give you all the risks and complications, because some things will happen 1 in a million times and we can't list all of those to our patients. It's just not practical. So this is our threshold, this is our standard, which we judge by what we should tell our patients on a day-to-day basis. So that's what defines informed consent, that we have given them information about the pros and cons, the benefits and risks, to a level that would be expected from the reasonable patient.
Okay, so we've talked about the fact that consent must be given voluntarily and what that means, and we've talked about the fact that consent has to be informed. So lastly, consent has to be competence or competent. And what that means is that we have to make a judgment that this patient is able to make this decision in order to give their consent or to withdraw their consent. So we have a framework that we use as medics to navigate this issue, and that's called the Mental Capacity Act. It was written in 2005, and that act basically tells us how to go about assessing someone's capacity to make a decision. So in that act, we must, as doctors, in order to say that someone has consent, they must fulfill certain criteria. So in order to make sure that consent is competent, we have to check that patients are able to do certain things. So first of all, they must be able to understand a decision that they have to make. They have to be able to retain the information we give them. So when we're informing them of all of those risks and benefits, they have to be able to retain that information. They have to be able to weigh up that information in order to come to a decision. So they need to look at the risks and benefits, and we need to see that that's what they've done. And then they need to be able to communicate that decision to us as doctors, saying either that they've decided to consent or that they haven't consented. And if all of those principles are fulfilled, then we're able to say that this patient has capacity and that they are competent. It's worth noting that all adults are assumed to be competent unless proven otherwise, but we'll check in certain situations where a patient might seem to be making a strange decision, and we have to assess their capacity further to make sure that it's a capacitous, competent decision.
Great, so we know that to have valid consent, it needs to be informed, it needs to be voluntary, and it needs to be competent. But what about with kids? You might have heard the phrase Fraser guideline or Gillick competence. We're going to explain what those mean. Charlotte and Molly coming up right now.
Okay, so we've talked about how consent in adults must be given voluntarily, it must be informed, and it must be competent. But what about in kids? What happens with children and consent?
So there's two things we need to think about. So 16 and 17-year-olds, and then below 16-year-olds. So the law distinguishes 16 and 17-year-olds as something slightly different. So this is under a piece of legislation called the Family Law Reform Act 1969, and basically the judge said that if someone is 16 or 17 and can do all the things we expect an adult to do, so can understand, retain, weigh and communicate a decision, if 16 or 17-year-olds can do all of that, then their consent shall be valid as if they were 18. So that's 16 and 17-year-olds. The differences with them is that they can't refuse treatment if a parent or guardian gives consent. So if a 16-year-old says, no, I don't want that operation, but their parent says, I give consent, the operation can be carried out even if they have refused treatment. So the difference with a 16 or 17-year-old from an adult is that they can consent, but they cannot refuse. So then below 16 years of age, children might be deemed to be competent, to have the capacity to make a decision. And this is known as Gillick competence. And the case surrounding this was a woman called Victoria Gillick who wanted to ensure that her children, her female daughters...
Only the female daughters.
Only the female, not the male daughters. Victoria Gillick, who wanted to make sure that her daughters who were under 16 couldn't receive contraception or contraceptive advice from their doctor without her knowing, without her being informed. And the health authority went to court with her, and they came up with this idea of Fraser guidelines and Gillick competence. So basically, if a child who's below 16 can do all of those things, understand, retain, weigh and communicate, and we are satisfied that they are able to do that, then they can give consent as if they were an adult. What they can't do is refuse, again, similarly to 16 and 17-year-olds, they can't refuse. And it's unlikely that if you're below 13 years old that you're going to be deemed to be competent to make a decision. And of course we have to remember that decisions can vary massively on a scale. So giving consent for a blood test is not the same as giving consent to receive an organ transplant. And so a 14-year-old may well be competent, have capacity to understand the risks and benefits of having a blood test or receiving an immunisation, and that would be absolutely fine. But in terms of if I was going to offer them a lung transplant, could they understand all of the risks and benefits and weigh that? And that's a far more complex decision. And so they might be capacitous to make a decision about having an injection or a blood test, but they might not be capacitous to make a bigger decision about an organ transplant. And it's important to remember that this capacity is function specific and it can vary. So if someone is very unwell with a nasty infection, they might lose their capacity because they're confused, but 2 days later when they've had a course of antibiotics, they're absolutely fine again and have got capacity to make decisions. So capacity is function specific and it is variable, and so that means we have to continually reassess. We can't just have a blanket decision that lasts forever.
So that's what happens with kids. Basically, as long as someone under the age of 18 can do those 4 things that we need to assess capacity, i.e. understand, retain, weigh up and communicate their decision, then they are treated as having consent and they are able to consent to things being done to them, like procedures, blood tests, whatever. However, if they're under 18 and they refuse treatment, even if they have all these things of capacity, then the person with parental responsibility can consent on their behalf. So you can override their refusal of treatment. Okay, so that's all well and good. Now let's talk about what happens if a patient does not have capacity but needs some kind of treatment. And we can imagine the scenario where a patient comes in unconscious to the hospital and needs some kind of life-saving procedure, but you know they're unconscious, so you can't assess their capacity, you can't get their consent. What do we do in those cases? Firstly, Molly is going to introduce the idea of advanced directives and LPAs, lasting powers of attorney. This is definitely beyond the scope of what you need to know for your interviews, but we've included it here just for completeness, and it's pretty straightforward. So I think if you can understand it, then it just makes the whole consent thing a lot more manageable. So here's Molly talking about ADs and LPAs.
Okay, so we've had a look at what makes consent valid, and in particular we've looked at the fact that you have to assess a patient's capacity. So thinking a bit more about that and thinking about what do we do when a patient doesn't have capacity and we've assessed that they are unable to do all of those things that we said they had to be able to do in order to give consent. So there's a few things that a doctor can do and a few sort of pieces of legal information that we can look to if we think a patient isn't capacitous. So firstly, a patient might have something called an advance directive. So this is written by the patient themselves and it's saying what they would and wouldn't consent to in the future. So a patient who has a disease which they expect to in the end stop them from having capacity in the future, at the time when they did have capacity in the past, they can write down this advance directive and specifically state what situations they would have consented and in which situations they wouldn't have consented. What's really important here is if the decision is about anything to do with life-saving or life-preserving treatments, then it's really important that the patient has signed it, dated it, that it's been co-signed by a witness, and that they have specifically stated that they would not be happy to receive treatment that would be life-saving. So there's a few more sort of loopholes that you have to go through if you're talking about life-saving treatment, but advanced directives can be about any sort of treatment. Another thing that we might look at if there isn't an advanced directive or if this was created since an advance directive, we can go towards a lasting power of attorney. So a lasting power of attorney, or an LPA, has two forms. It can either be a sort of health and well-being LPA, or it could be a financial LPA. So it's worth bearing in mind that if someone has a financial LPA, it's not going to make any difference to medical decisions. So we're looking at the health and well-being side of things. If someone has a health and well-being LPA, that means that they have nominated someone else to act in their best interests. So again, this person has previously known that their capacity may at some point go, and so they have made a decision to nominate someone else as their LPA, as their representative, to make those decisions for them in the future. We have to make sure that we think that this LPA is acting in the best interests of that person, and if we have any doubts about that, we can actually refer to someone else called a IMCA, an Independent Mental Capacity Advocate, and these IMCAs can actually make a decision. They're someone who's not known to the patient. It's their job to represent the patient's best interests, and they can actually make a decision on the patient's behalf.
Okay, so if our adult patient does not have the capacity to consent to something, then we check to see if there's an advance directive or a lasting power of attorney in place, and we consult those if appropriate. But what if, as is quite common, they don't have either of those things in place? What if I were to be rushed into A&E, like, intoxicated or completely unconscious, and obviously I don't have an advance directive or a lasting power of attorney, and they need to do an operation to save my life? What are the doctors going to do then?
If we've done all of that, if we've assessed our patient and we're not happy that they've got the capacity, they haven't got a lasting power of attorney, they haven't got an advance directive, and we're in a situation where we've got to make a clinical decision. Ultimately, we have to decide what we think is in the patient's best interests. It has to be a best interest decision. So that means, as doctors, that we take into account what the patient may have wanted, and that means we have a duty to talk to friends and family about what their religious, cultural beliefs were, if that would influence their decision. We have to understand the interventions that could be put in place and what the quality of life the patient would have afterwards. And we have to decide as a healthcare team what is going to be in their best interests. And so that doesn't fall to one doctor on their own. It's really important to remember that you're never working on your own as a doctor. And so it will be a whole team decision with the junior doctors, the senior doctors, the consultant, the nurses, physios, occupational therapists, the whole multidisciplinary team will make that decision together. And sometimes that's really hard, because sometimes the decision will be, it's not going to be in the patient's best interest to send them to intensive care and to intubate them and ventilate them mechanically. And that decision is really hard, because of course patients' families want them to stay alive, and as a doctor, that's one of the really big challenges that is faced. We have to make these decisions in the best interest of the patient, even though sometimes that's going to be really distressing and really difficult for families. We have to act in the patient's best interest.
Okay, so we've talked a bit more about consent and what it means to give valid consent. And we've also spoken a bit about the fact that doctors, in the end, have to make decisions in a patient's best interest and take into account what they believe the patient would have wanted. It's worth noting that this best interest argument was one of the key points in the Charlie Gard case that you might have seen, which played out at Great Ormond Street this year. There'll be some more information in the description below, and we may end up doing a video in the future discussing particular things about Charlie Gard and how that case came about. But essentially, it was a best interest decision from the doctors involved.
And there we have it. Everything you need to know about consent and capacity and Jehovah's Witnesses, which can sometimes come up in interviews. Basically, we need to give valid consent before we do anything, otherwise it's assault. To get valid consent, it needs to be informed, it needs to be voluntary, and it needs to be competent. In order for it to be competent, the patient needs to be able to understand, retain, weigh up, and communicate their decision. And if a patient doesn't have capacity for any reason, then we look to see if there's an advance directive or a lasting power of attorney in place, and if not, then we operate on a best interests principle. We've talked a little bit about the cases that form the basis of some of the laws around capacity and consent, and I think it's important to know a little bit about them. I think it's obviously not required knowledge, like you don't need to be stating like names and dates and whatever. But I think if you do get asked a question about Jehovah's Witnesses, and you can reference the example of the pregnant lady who was in a car crash, but then her mum, was exerting undue influence. Even if you just know vague details about the case, it looks really, really impressive, and it looks as if you've really made an effort to try and understand this whole medical ethics and law thing in preparation for your interview, which shows commitment to medicine and all of that, which they're definitely looking for. So yeah, that's it. Consent, capacity, and Jehovah's Witnesses in hopefully a short and sweet nutshell. Thank you very much for watching. Our next video, which will hopefully be coming out next week, a week after you see this, is going to be about euthanasia, assisted suicide, do not resuscitate, all that heavy stuff. But as is tradition with this mini-series, I'm going to leave you with Charlotte and Molly, who'll be saying a few final words, summing up and saying goodbye. So thanks, and I'll see you next time.
So thank you again for watching. We hope you found it useful. Let us know if there's anything else you'd like us to cover in the future. And we'll see you again for some more fun ethical discussions. Bye! Oh god, I have a headache.